Hear you.
Sounds good.
Perfect. So I just want to briefly introduce our guest speaker who comes to us from our friends up north. Dr. Cheema trained in both, well, tell us a little bit about both vascular surgery and I think then cardiothoracic, if I have the order correct on it. And has been involved in the structural program for a while at Hartford, but it's really been one of sort of the pioneers in pushing forward transcarotid access as a way to treat patients with TAVR who don't have iliofemoral access. We've reviewed, I think, in a variety of meetings, sort of different alternative accesses. The first one that was transapical, then the next one, which was probably subclavian, and then direct aortic. And I know we've reviewed some cases of things like cable, but there's been some really impressive data that's come out on transcarotid as potentially being after transfemoral, a real way to consider treating patients. And in fact, today we have a patient who we're going to do a transcarotid TAVR on. So wonderful to have Dr. Cheema here talking about sort of the work he's done in that area. So welcome to Yale and thank you for joining us.
Thanks, John. Thank you, everybody, for the opportunity. So yeah, John had asked me to kind of talk about the, alternative access in general, and more specifically about transcarotid access and how it has changed our approach in terms of managing some of these difficult access patients in order to do a TAVR valve safely. So again, my background, I do have a fellowship trained certification in both cardiac and vascular surgery. So that may be the reason why I feel comfortable exposing carotid arteries and working around it. But nonetheless, I think overall, in general, I think there is all around US more and more push for using this approach because we have seen better outcomes compared to some of the other alternative access procedures that we do. So let me just kind of briefly review what we have in the data. So obviously the biggest thing that we talk about when we're doing alternative access is risk and incidence and impact of vascular complications. If you look at all the partner trials, there's been, and then, these are all patients who were selected based on, decent transfemoral access, despite having good femoral arteries to deliver valves. There was about a 30% risk of major vascular and 11% risk of minor vascular complications in those trials. And some of the meta-analysis showed a combination of about 12%. So not benign, even in so-called, good femoral access patients. The problem is when you have vascular complication, especially major vascular complication, there is about a fourfold increase in 30-day mortality, and also increases the length of stay, the cost, the wound complications, and more importantly, renal insufficiency, which can impact the mortality as well. And if you follow these patients long enough, you will notice that, not all of these patients make it to 1 year, especially if they have a major vascular complication. So not benign to have vascular complication, even if they're minor. We're not going to go over some of the risk factors for vascular complications. You're all very familiar with those, but there are some modifiable and there's some non-modifiable risk factors that are listed there. In terms of research, there's not a lot of level 1 data comparing one access over the other. These are mostly either single center, large center reported outcomes, or TVT registry data. There's no randomized controlled trials that we know of as of now comparing the different accesses. As far as the carotid access is concerned, this was one of the earlier papers. It's from Europe, from France. It's a multi-center approach. They published at JACC It's about 300 plus patients. It's about 13 or 14 centers around France that were contributing to this paper, and they had started to use more and more carotid access. And this is the paper that reported their outcomes over the last 5 to 7 years. Median age, again, these were high-risk patients, 83 years, majority male. STS risk factors were close to 6% risk of mortality. So a high-risk group. And as you can imagine, a lot of these patients had peripheral artery disease, about 64%. They performed transcarotid TAVR under general anesthesia in most of these patients, and they used left carotid artery for about 3/4 of them. Procedure success was 97%. What caught my attention was the mortality was very comparable to other alternative access, 3.2%. And more importantly, the stroke risk was only 1.6%, which was very good if you look at these alternative access cases and compare them to direct aortic, transapicals, or axillaries. So in their conclusion, transcarotid TAVR using an Edwards sapien device was safe, effective in a multi-center registry, and it might be considered in selected patients as a first-line alternative approach when transfemoral access is not feasible. So when we talk about transcarotid, obviously you got to weigh the pros and cons. I've listed some of those there, but there are more and more as we learn this procedure more and more and apply it more widely. Some of the pros, obviously you're not opening a chest when you're talking about elderly, frail patients with high STS risks. So you're not doing spreading the ribs by doing a transapical or even a mini sternotomy. These patients don't tolerate that well. So it's less invasive. The ambulation is not limited. These patients can walk right after their procedure because the artery is surgically closed. There's no hemostasis that needs to take place. It is a good option for patients if they have had previous CABG and they have a Nema graft that's applying majority of the blood flow to the heart muscle, or if they have a pacemaker in place, it's not easy to expose the left axillary artery in those situations. You can use either side, right or left, and depending on the anatomy, whichever provides the least disruptive access to the valve. And it's very doable, and even in morbidly obese patients with BMIs over 50. Some of those patients trying to access their axillary artery, it can be a chore. I mean, it's really, it's a deep cut down. You got to go through a lot of muscle. There's a lot of nerves, and the veins are wrapped around the axillary artery, and it takes a while for that incision to heal. And you're cutting a lot of the muscle through, and these patients will sometimes have chronic pain syndrome from that. So it's not benign to expose axillary artery in a large patient. So what are some of the cons? Obviously, risk of cranial nerve injury. The only cranial nerve where we expose the common carotid artery is the vagus nerve. And we'll just go over some of the technique to avoid injury to that. If you can avoid injury to that, because that could be pretty morbid, because recurrent laryngeal nerve on that, especially on the left side, actually on both sides, is still part of the vagus nerve at that level. So if you damage that, you'll have permanent hoarseness sometimes. That cannot be denied. So just something to be aware of in terms of risk of cranial nerve injury. But on the other hand, when you're exposing axillary artery, you got to worry about the brachial plexus and stuff. So we're still doing general anesthesia for most of these patients, but general anesthesia, short or brief general anesthesia, even in a high risk pulmonary cripple patient, is very well tolerated. Most of these patients get extubated right away. The procedure is short. You're not opening the chest, you're not spreading the ribs, you're not doing a sternotomy, so recovery is very quick. There can be significant concomitant carotid artery disease, which can sometimes be an exclusion depending on each individual scenario. Sometimes, we will still use carotid access as long as they have developed collaterals from occluded other side. So it all depends case by case scenario. Neck incision sensitivity is not a problem at all. An injury like any other TAVR is a concern, but it's really not a big deal. With common carotid artery, is a very sturdy, very strong artery to work with. compared to an axillary subclavian. A lot of surgeons will know this because the axillary artery is a friable vessel. It can easily fall apart on you, and once it does, it's no easy way to fix it because it hides under the clavicle and then it disappears behind the shoulder. So you have a limited amount of area where you can access the vessel and can do a safe repair. But if you do develop a dissection, then it becomes a problem. On the other hand, common carotid artery is a lot more sturdier artery, easy to expose, easy to work with, and usually provides a more direct access to the aortic valves. I'm just going to go over some of the like I said, most of the data that we have is more robust data, the registry level data comparing the different approaches. This was a paper that was presented at TBT and was published. We were part of that publication as well, where we compared transcarotid. This is all TBT registry data, all comers, where we compared transcarotid to a direct aortic or transapical in a TBT registry. It's about 667 transcarotid versus 1100 direct thoracic approach. You can see that every time you're opening a chest or a pericardium, it becomes an invasive procedure. It's almost like doing an open valve. The mortality, the new risk of new onset AFib, length of stay, readmission rate, ICU, length of stay, are all significantly higher in patients who get either direct aortic or transapical when we compare to a transcarotid approach. The stroke risk was similar in that paper. So it's not a benign procedure every time you have to open somebody's chest. This is the other paper that was recently published, and the data was presented at both TCT and the STS. And it was published in the Annals of Thoracic Surgery. Again, TBT registry data comparing all comers transcarotid versus a subclavian or axillary approach. It compiled data from June 2015 to August 2019. All comers, 121,000 sapien 3 cases. They excluded all the transfemorals, direct aortic, transapicals, others, valve and valve cases. So what you're left behind is a 667 transcarotid cases compared to a 2,800 axillary subclavian TAVR cases. You can see this, the trend over time. In general, when we talk about the TBT registry data, the overall trend in alternative access, and you can see that the direct aortic transapical has gone down significantly. The axillary subclavian was the main access route for delivery of the valves. But in the recent years, in the last 3 or 4 years, the transcarotid approach has really taken off. And pretty soon, I think you'll see a crossing of the two lines between axillary and transcarotid. I think we're seeing more and more that the centers are getting more comfortable with transcarotid approach. And once you get comfortable with it, there's no way you'll go back to transaxillary approach. Obviously, it all depends on each individual patient's anatomy, but between the two of those, I think you can pretty much satisfy almost 95% of the alternative access needs. The direct aortic and transapicals really should be reserved for less than 2% of the cases. Again, based on this paper, in the last several years, the transcarotid access cases have gone up significantly. This is the plot of the median number of cases that were done at all the registry sites. You can see there were a lot of sites that are done less than 10 cases. They were all part of this paper. And then very few sites that had, more than 70 or 50 cases. The top 10 sites had performed 55%, but the rest of the cases were done with low volume centers. So it was a mix of everybody doing transcarotid in that registry paper. So what were the outcomes? You can see the device success delivery is equivalent. The procedure actually is a lot shorter when you're doing transcarotid approach. Thoracoscopy time, the contrast volume, conversion to open, annular rupture, a use of cardiopulmonary bypass was the equivalent. So a lot more streamlined, a lot more shorter procedure when we're doing it through a transcarotid approach. The mortality was equivalent. The stroke risk was borderline significant and was lower in transcarotid approach, about 4% versus 6%. Again, these are all comers, all centers, everybody putting in their data. So it's a mix of everything. But in our center, the stroke risk is approaching less than 2%, almost 1%, comparable to transfemoral approach. New onset AFib, readmissions, need for dialysis, pacemaker, life-threatening bleeding, the rest of the stuff was equivalent between the two. This is the mortality. It's equivalent between the two access procedures. The stroke risk is slightly lower with the transcarotid approach, and when you combine, gives a little bit of advantage to transcarotid approach. And when you plotted, unadjusted comparisons, everything seems to favor transcarotid approach in terms of mortality, the stroke, new onset AFib, readmissions, pacemaker, major vascular complications, kind of borderline, but favoring more towards the transcarotid approach. So I'm just going to switch gears and just talk about the procedure itself, the pre-procedure screening and how we approach it. And then we can, answer any specific questions about the case for today at the end. Now, when we have started to modify our pre-procedure protocol, when we scan these patients, we have asked our radiologists to use the same amount of dye, but to scan them from the base of the skull down to the femoral bifurcation, almost mid-thigh. So the same amount of dye that you would use for a regular TAVR protocol, but include the carotid bifurcations all the way up to the base of the skull, down to femoral bifurcations. We do routinely get a duplex ultrasound that gives you an idea about the carotid artery, especially internal carotid artery flow on both sides, as well as vertebral artery flow assessment. It not only gives you an idea about the proximal stenosis in those vessels, like let's say a left subclavian or a proximal left common distance, low velocity flow, that that there's probably significant intracranial occlusive disease that may need to be looked into with the specific CTA of the head and neck, especially if the patient has had previous stroke. So a lot of information you can get based on the duplex and the CTA, like I mentioned. And then we do the 3 Mencio carotid workup and the annular workup, like the rest of the TAVR workup. In old days, the decision was we were still using Certitude system, which is the direct apical, direct aortic sheath that we use for delivery of the TAVR. And that's a 21 French system. It's a pretty large sheath. Versus now we've gotten almost away from using Certitude for all of our transcarotid cases. We're routinely using just Commander system. Again, much lower profile, 14, 16 French for delivery of all the valves. And our risk of vascular complications have gone down significantly. So standard surgical equipment that you use for carotid endarterectomy, 6070 Prolene sutures. There's no added expense. Some vessel loops, vascular clamps, Robichaud's, tourniquets, the usual stuff that you have on your surgical carotid trays. We do routinely perform EEG and sscp monitoring at this point, but we're slowly moving away from that just to avoid added expense. I think if you have cerebral oximetry, that usually would suffice. Very important to know the arch anatomy and the variations, because sometimes elderly patients, the arches tend to be more type 1 or, type 2 or type 3 Gothic kind of arches where everything moves more towards the ascending aorta. All the head vessels and the aorta gets more tortuous, especially the descending aorta, the more angulated. So in those patients, it's actually more favorable to come from the carotid artery because it provides direct access to the aortic valve and the root. And it essentially becomes a no-touch technique, and that's where the stroke risk comes from. Most of these strokes are embolic strokes when you're causing trauma to the arch. You're scraping a lot of that atherosclerotic disease or atheroma, trying to deliver the valve, especially coming in from the left subclavian approach, a lot more trauma to the arch. If you come in from the carotid, once the valve is past the ostium of the common carotid artery, it really doesn't touch any of the walls of the aorta and goes straight into the aortic annulus. So, but it is important to map out the arch anatomy and figure out which side provides a more direct approach with the least amount of trauma. It's a little busy slide, but you know, the anatomy in that area is basically it's the SCM, sternocleidomastoid muscle that goes from the mastoid process down to the sternum. That muscle is taken away in that picture. And once you go, the incision is usually in the lower end of that, anterior to the SCM muscle. Once you go through the platysma, you're going to find this omohyoid muscle. You get through that, and the next thing you'll see is the jugular vein. You retract the vein laterally, and the artery is right there. The vagus nerve travels posterior to the carotid artery, so you have to carefully mobilize it away from the carotid. I usually do a circumferential full mobilization of the entire vessel from here down to the thoracic inlet, and so I can lift the artery out of the wound. It's easier to insert the sheath, and at the end you can safely place clamps in without causing injury to the vagus nerve.
You lifted out of the one with vessel loops.
Yes, I usually put one vessel loop proximal distal. That way you lift up on it, it just pulls out of the wound.
Got it.
Like I said, neurologic monitoring, we're still doing sscp EEGs, but cerebral oximetry is fine. Some people use transcranial Dopplers, just more cumbersome to set up, and you just don't know what added information you need based on that. Really doesn't change the outcomes at all. So before, it used to be, I used to clamp all the common carotid arteries before we access the artery, just to avoid any embolic debris, but really I stopped doing that because the less trauma you have to the vessel, the less the risk of injury. The only trauma that you get to the vessel is when you're inserting the big sheath and when you're pulling it out, and then you do a surgical repair of that. Really, the risk of embolization is extremely low. The only time you can cause embolic stroke is when you're flushing your sheets, make sure you don't have any air in your syringes, and also, you know, risk of trauma to the aortic wall when you're advancing the valves. I used to extend the arteriotomy over the wire. I don't do that anymore. I just let the sheath kind of do a very controlled dilation of the vessel. And most of the time it's a transverse tear, almost 98% of the times. Once you pull that sheath out, it's very easy to repair all three layers of the vessel. We do recommend a proper surgical repair to clamp the artery after removal of the sheath, proximal, distal, and do interrupted Prolene sutures to make sure you grab all three layers, adventitia, intima, and media. And I do like 6 or 7 interrupted 7-0 or 6-0 Prolene sutures. Usually don't use any drains, even if the patient is anticoagulated. This is our typical setup. Most of our cases are done from the left carotid approach. So the patient's head is obviously towards the anesthesia. The C-arm is coming in from the patient's right side. The monitor is right in front of us as we're doing the procedure, and we're passing wires and catheters with the right hand. We're looking at the screen right in front of us, right next to where anesthesia is. And that usually the floor table goes in at right angle to where the patient's head is. So all the wires and catheters are just kind of sitting on that table as you're passing them down. Exposure is through a very small incision. You don't really need, there's a lot of mobility in the skin. So it's even through a small incision, you can expose about 7-8 centimeters of that artery and circumferentially mobilize it and pull it out of the wound. So really don't need to do a big cut down. Just gonna go over the steps. Obviously you do a small cut down lower towards the sternum, sternal edge of the SCM muscle, anterior to the muscle. You'll see right there that I usually use my retractor to kind of retract that vein away. And then an artery right there. Circumferentially mobilize the whole vessel for a fair distance. And the first thing we do is over here, you'll see a clamp in place, but I usually stop clamping the vessels even with a short sheath. We access the artery, we lift up that number 5 tie more towards the head of the vessel. To lift the artery out of the wound, puncture the artery anterior wall, pass the wire, and then you can relax on that number 5 tie. Once you have your 6 French sheath in, I usually have my assistant pull that sheet so the sheet doesn't get pulled out when we're doing wire and catheter exchanges. The 6-French sheet goes in. Like I said, you don't need to clamp the distal common carotid artery. The risk of embolic hit should be fairly low if you're very careful with flushing the sheet and make sure there's no air there. So once you have the sheet in, you cross the valve, you do your hemodynamics, you put your stiff wire, and then you're ready to put the big sheet in. Before you insert the sheet, you ask your anesthesiologist to bring the systolic blood pressure in 130, 140, 150 range, just to help improve collateral circulation from the other side, because from this point on, the common carotid artery is going to be essentially occluded because of the big sheath in place. This is a 2-person sheath insertion. You make sure you have a little bit of an arc with the vessel. You're going in, I usually put my index finger behind the artery. So when I insert the sheath, I don't snowplow the posterior wall or the intima. And then it's a very atraumatic sheath insertion. You watch it under fluoro. You make sure the distal end of the tip is past the origin of the common carotid artery. And you watch it obviously under fluoro. Sometimes I would even cross the valve with the dilator just to kind of daughter the valve. That way you don't have to do balloon valvuloplasty. But just be careful that your sheath dilator is going through the valve. It's not a big deal. The other thing you have to be very careful about is to make sure the wire is all the way into the apex, because you don't have a lot of room between where the sheath comes in and the valve is located. So, and then I have a dedicated person, usually a PA, that will help do these procedures. Her or his job is to hold the sheath straight out at a slight angle as an arc with 2 hands. And once the sheath is past the ostium of the common carotid artery, the sheath should not move. It should not go in when you're passing the valve in. There's a lot of forces on that sheath, or it should not pull back into the common carotid artery. If you inadvertently push it against the ascending aorta, you can cause a type A dissection. If it pulls back into the common carotid artery and you advance the valve bareback, you can cause an injury to the common carotid. So very, very important to have a dedicated person holding that sheath in place. Again, just to re-emphasize, have an assistant holding the sheath and she's facing us. We're looking at the screen. He or she's standing there and holding the sheath as we're passing the catheter. And that sheath stays straight. You make sure you don't bend that sheath, but if you do, almost 2/3 of that commander's sheath is hanging outside the artery. And that expandable sheath is going to get disrupted once you pass the valve through it. And if you kink it too much, it can start bleeding on you. So you don't want that. The other thing is you don't want to kink the sheath, because if you're trying to advance a valve through a kinked sheath, you can deform the valve. We have had one case where it happened, and it was just not a good situation. So again, a dedicated person holding the sheath straight, holding it with 2 hands. Your sheath cannot go in or pull out, and you maintain a little bit of an arc. At the end, once you're done with the valve delivery, you do a surgical repair, clamp, and 7 or 8 interrupted sutures. Make sure you get all 3 layers of the artery. And then I usually do an epi-aortic scanning of that vessel with a hockey stick probe or something to make sure there's no intimal trauma or a dissection flap. Or you can do a selective angiography. Either one is fine. And that's the end result. So in terms of our data at Hartford, our approach has obviously evolved like everybody else. In the beginning, when we started doing these cases, there was a big, large bore sheets. So about, I would say more than 20-30% of the cases were alternative access. We were obviously, like all the other programs, we were using direct aortic or transapical. As we progressed along, the sheet size got better. We started using more and more femoral. At one point, we were almost 90+% transfemoral. And we started using more and more subclavian axillary approach. And in the last 4 or 5 years, since we've gotten more comfortable with transcarotid and our outcomes have improved, we're pretty much switched to almost 90+% of our alternative accesses using a transcarotid. And like all the other programs, we were trying to push more and more transfemoral, even in marginal cases where you have a lot of disease. And we saw that the vascular complication rate was quite high. And we were not satisfied with that. So we started to strike the balance, and we use more and more a transcarotid approach on marginal cases where we think that would be a risk of injury to the vessels. And right now, our fine balance is about 85% transfemoral, about 15% transcarotid. Alternative access, and majority of those are transcarotid. And our outcomes have improved. You can see all for cases, the transfemorals are all at the top, and the transcarotid, transaxillary subclavians are about 84 of those cases. In the last 3 years, we have done very minimal of those. Most of those are transcarotid, and direct aortic transapical have really gone down significantly. And you can see our outcomes have improved as we evolved from the bottom, which is the direct aortic transapical, to transaxillary to transcarotid. Our outcomes have improved. The stroke risk has improved, almost down to 2%, very close to a transfemoral approach, and our mortality is almost zero. And so our vascular complications, both major and minor, is very comparable to transcarotid, trying to do transfemoral. So I think with evolution of our alternative access to transcarotid, we have had outcomes almost as good as transfemoral. So we're really comfortable, even in high-risk patients, offering this approach. We can get them through it with minimal morbidity. So in conclusion, obviously patient selection is key. Pre-procedure screening with adequate CTA is important. Intraoperative monitoring, I think you should have some sort of monitoring early in your experience. When you get more and more comfortable, you could probably get rid of that. Post-op, I do get a carotid duplex in post-op day 1 and at 30 days, just to make sure that there's no injury to the vessel. And if that looks good, then you don't need to do any more further surveillance. And obviously, team's level of experience are comfortable with, or comfort level with alternative access route is important as well. So I'll just stop there.
Awesome, thank you.
Sure, there's specific questions about the approach. Obviously, the first time you guys are doing it. I did get a chance to talk to Matt Williams yesterday.
IME.
Awesome. So, any surgeon can expose the carotid artery. Once you get comfortable with it, early in your experience, you may want to get vascular surgery on board. Just, politically can be a problem depending on each institution's, dynamics and stuff. But, at the end of the day, it's a really easy artery to expose, easy to access, easy to repair, and very rarely you get into a major vascular complication.
So can you tell us some examples of disasters?
Yeah. So the biggest disaster that you'll have is maybe a carotid artery injury, like a focal dissection. And that most of the times you can either put a stent across, like a bare metal stent coming in for transfemoral, or if it's very focal injury, you can just resect the artery and replace it with a graft, 8mm Dacron or PTA graft. I had to replace the carotid artery probably 4 or 5 cases so far. Again, this was early when we were using more certitude, 21 French system, a much larger device. In the last, 70 or so cases that we've done with Commander, it really has been a minimal risk.
Good.
All you need is at least 5.5mm artery. Most of the common carotid arteries are free of atherosclerotic disease in that area. There's not a lot of calcium. The only disease that you may encounter is at the level of the ostium as it comes off of the arch. And as long as it's not circumferential and it's not more than 50%, you can get about. So
I got another question. That's okay.
Yeah.
Could you talk a little bit about your the selection of which side of the artery to use in relationship to disease in the vertebral arteries or size of the vertebral arteries? Just
it really depends on which artery gives me a more direct approach. Sometimes when you have the innominate and the common carotid comes off way off of the distal arch. So coming from the right, you'll have to go like that and come back down. Probably not a good approach to come from the right. If the left side usually provides a better access, you can hug the outer curvature of the ascending aorta. It's a more favorable, almost 70% of the cases of left carotid.
Okay.
But sometimes, in the older patients where everything moves, all the head vessels, the brachiocephalic arteries, everything seems to come off more in the ascending part. And then it's a direct approach, even from the right carotid, straight down.
And how do you think about the vertebral artery findings on
I
the?
usually don't pay much attention unless patient has severe bilateral subclavian occlusive disease or severe bilateral carotid stenosis. Those are the patients you probably shouldn't be doing this, or at least early in your experience. I usually don't get worried about it too much. The common carotid artery, brief clamping or occlusion for about 10, 20, 15 minutes is very well tolerated. A lot of collateral flow even from ECA to ICA on the same side or from the other side. As long as you keep your blood pressure up, you should be fine.
And the target should be 130 systolic there. So it should tell your anesthesia.
Yeah, I think it depends on each individual patient. Usually at least, between 120 to 140, 150.
Got it.
Do you have a need to, I guess, two questions. One, sort of your choice of valve for it, be either a self-expanding or a balloon expanding. And then if, I know you've done a lot with the balloon expanding. Do you need to flex your catheter at all as you're coming? Do you load it? I mean, I guess it'll be the same way, right? 'Cause it's still turning this way.
Yeah. So from a transcarotid approach, especially if you have a more horizontal route, anything over 45 degrees becomes a problem with the self-expanding because it just wants to go straight down. It doesn't do that. It just wants to go straight down. It's very hard to align the bottom of the valve to the cusps. The sapien, obviously, you have that flex with the commander system, so you can use that flex to your advantage. We have been more and more aggressive, and even in horizontal aortas or roots, even up to 70 degrees, you can get it aligned easily. So, but one difference is obviously when you're coming from the carotid approach, you have to move that valve onto the balloon in 2 or 3 different steps. Yeah. You have a limited amount of space between the tip of the sheath and the valve, so you have to do it in 3 different steps. Unlock, move it back, lock it, advance it, do it in 3 steps until you're completely aligned. And then use your flex to your advantage to deliver the valves.
And it flexes the same way.
Yeah. I don't know if you want to review your case, if you have the 3 Mencia workup, otherwise.
Maybe we'll review it in the OR with
In the OR? Okay. Yeah,
folks that are there.
sounds good. Any anesthesiologists here or?
No, Dr. Rady's on the OR.
Yeah, I'm
Oh,
here.
here.
Hi. We actually going in the room. Going patient is in the room already. I'm just curious. You guys, I know you said you guys doing quite a bit of it. Have you entertained the sedation? Because I know there's like papers there by French, I think, cardiologists doing it on the sedation.
Yeah, good question. I think I would say there's really not much difference between a brief general anesthesia and have a controlled airway and hemodynamics, rather than having a flailing patient in the middle of a local anesthetic and a transcarotid approach. That would scare me. Although, people have done it, and they almost do it under general anesthesia, but the patient is not intubated. But,
Right.
I think if you wanted to do it, I would just start with general anesthesia, pick, regular straightforward cases first, get comfortable with the approach, and then maybe move it to local with sedation. But honestly, brief general anesthesia, even in patients who are pulmonary cripples, we usually extubate them right away. It's a very short procedure, so.
Got it. Thank you.
You did. As long as
Have you done any cases with the self-expanding?
Yes,
Yeah.
we do. We're about 30% of our volume is transcarotid, is self-expanding. So like I said, if your route is not too horizontal.
Yeah.
And there's a patient that you would rather do a self-expanding, you can use it, but it's a little bit different valve, obviously, depending on whether you want to use a sheath or just go bareback.
Yeah.
You're gonna have to use a certain 18th sheath if you go with the sheath versus just the inline. You don't have a lot of room at the distal end of the inline sheath to do maneuvering of the valve, so it can be a little bit tricky, but if you use a long sheet, then you have all that added length of the sheet to do your maneuvering, so you can do it.
Do you think that, I've seen one case published recently of a percutaneous carotid to put an impeller. Do you think that will ever, take off percutaneous access of the carotid? Or whether it should?
We have talked about it. I worry about the consequences of a dissection or injury to the common carotid. It's not an axillary artery. You can get away with a dissection. It's a common carotid artery. If the dissection goes up into the intracranial vessels, you're looking at a massive stroke. But yeah, I mean, if you have a reason to not do a cut down for whatever reason, people have used it, and gotten away with it. Nobody publishes their bad outcomes, but
Thank you, I'm all right.
yeah. So
You have, how many of your surgeons are doing it?
So it used to be two of us, David Underhill, he's retiring now, so it's primarily us. I think, again, as you get more experience, maybe have one or two surgeons get comfortable with the access, so they do it all the time, know exactly what to look for and stuff, rather than have everybody. So in our program, same way, most of our surgeons do them transfemoral. I do most of the alternative access, but we'll probably have one more person trained.
Now that you're so comfortable with transcarotid, what level of femoral disease would you guys say actually, let's.
Yeah, that's a very good question. We deal with it all the time in our screening conference that we have every Thursday. I mean, literally, we're gotten so comfortable, even the cardiologists, hey, why don't you just do a transcarotid rather than using a, shockwave or put a couple of stents in. You're adding an expense to your procedure, like $3,000. If you put in a stent, a covered stent, that's another $2,000. The $5,000 to a procedure just to stay femoral. When you can do it as safely to a transcarotid approach with no expense at all. I mean, just a few prolines. So, like I said, in the beginning, it was, yes, that was the discussion all the time. But now even our cardiologists go, just do a transcarotid. So simple and easy.
And did the transcarotid, if everything has gone well, go home the next day?
Next day, absolutely. 90%, 80% like everybody else, as long as they have no pacemaker needs. The incision is surgically repaired, there's no bleeding, there's no complications. I usually don't put adapt or anything just for transcarotid, whatever your anticoagulation, just use that. If it's just aspirin, just use that. If the patient needs to be on DAP, then
And you should, what level of ACT you guys go? Do you go
300, yeah.
300? You go a little, do you do that for all your TAVRs? Do you go
Yeah.
a little higher for your?
Transcarotid is 300 plus,
Okay.
transfemoral is 250.
Okay, yeah.
Just because, the vessel is clamped and, for a short, even though it's a short period of 15 minutes.
Anything else online?
I think the biggest question people get worried about is the collateral circulation and what do you do when you start seeing sscp EEG changes. My thing is keep going. Just ignore it. Keep your pressure high and just keep going. By the time you figure out what to do, you're already done with the procedure and ready to pull the sheath out and put the artery back online. Really, like I said, I'm probably at a point where I'm just going to get rid of neuromonitoring because it hasn't really changed my approach. Unless the patient has a contralateral occlusion or previous stroke or severe occlusive disease everywhere, then those patients, maybe a little bit more important to have neuromonitoring. But again, our dwell time in the carotid artery is literally 10, 15, maybe 20 minutes if it's a difficult valve. And by the time they start reporting changes, it's usually at a time when you pace, the pressure drops, takes a while for the patient to recover. Just keep going.
Is prior stroke a contraindication or not really? If the patient's had a previous stroke?
Depends on the situation. I think those are the patients you probably should be a little careful early in your experience. Once you get more comfortable with it, then again, depending on each person's anatomy, like for example, If I have a patient who's already had an occluded internal carotid artery on that side, he's already developed collaterals. As long as the common carotid is okay and the external is fine, I'm okay going to the carotid because, you know, it's most likely going to be fine. But if you have a occluded one side and a stenosis on the other side, then you have to be careful, obviously. So each individual patient's anatomy is different and what their circulation is like based on duplex and the CTA, you should be able to figure out whether carotid is a right thing to do or not. Have you guys done trans cables?
Couple, not for a couple of years though.
What do you think of,
They worked out okay. I mean, you know, I think we find more and more that, you know, we more have pushed the boundaries on transfemorals with good success. And we've found more and more that, you know, the patients that we really can't push the boundaries on for transfemorals, transcable is not really an option because the aorta is so diseased as you move up. And when we did our first handful of cables, you know, those are ones when we look back, we're like, we probably would have just gone femoral, you know, it's like 4-5 and calcified, but you know, we can take a balloon and things are smaller now. You know, we've done, I think primarily we've done subclavians with nice success. Our approach there has been to suture on a graft to it and then just to clamp the graft at the end of it. So you don't really have to repair the artery per se, and that's worked very nicely. You know, we've done we always do a handful of direct aortics, but I think those certainly are complication rates higher, you know, significantly higher. And I can't remember, you know, I can't remember the last transapical we did. I think maybe we did for, not since you've been here. Yeah, less than one a year. We still do it for, well, now not anymore, but most recently, I've obviously done it for our transcatheter mitral, although that's now femoral vein. But you know, I think our, you know, this, you know, I think it does. We're very comfortable with subclavian, and I think, you know, certainly I think the data is potential. I mean, right, that there's less complications with subclavian. I think what's very clear is that direct aortic and transapical are bad. Yeah. And that you know, whatever your third route, whether your third route is transcarotid or subclavian, you probably need it. And I think probably you have more exclusions. I don't know, it's a question for you. You probably have more exclusions for subclavian than you do for carotid because of the vessel.
absolutely. I think there's, you know, again, almost 80-90% of all alternative access is transcarotid, even though we're comfortable with both approaches. Friable the axillary artery is, and like I said, there's a Nema graft, you're occluding it temporarily, even sometimes that can be important. The patient gets hemodynamically unstable. If you have a pacemaker there, just a pain in the ass to expose the carotid, you know, axillary artery. You know, morbidly obese patients, not easy. You need like a deep abdominal retractor so you can't enter the artery. And you know, then the access, you're going down, up. I mean, it's just doesn't ergonomically, it's a lot more traumatic to the vessel and the arch coming in transaxillary. But, you know, again, maybe that's the reason why the stroke rate is a little less with the transcarotid, because once the sheath is in, it's a correct approach. It's minimal trauma to the arch or the ASIN. And we've done some really heavily calcified porcelain aortas, you know, really crummy calcified valves. We have even used, you know, a protection device and then nominate from the other side, and a filter, the left subclavian. If you're really worried about, you know, stroke, to kind of give you a full protection, and gotten away with very, you know, good results. So,
Awesome. Thank you very much.
all right, welcome.
Where are you today?
I'm gonna come up with it.
Okay.
Yeah.